Now we're going to see the invasive imaging lung testings. These include lung biopsy, bronchoscopy, open lung biopsy that we can include here, and video-assisted transthoracic surgery. So the lung biopsy can be done through surgery, through bronchoscopy, or through CT scan. In the CT guided lung biopsy, this allows us the real imaging of the lung tissue with the CT scan at the same time in which we can perform the transthoracic lung biopsy. Here we should be careful in a epiphysematous patient due to increased risk of pneumothorax. The indications of lung biopsy are, for example, a peripheral nodule that cannot be reached by the traditional transthoracic needle biopsy. The bronchoscopy, this could be rigid bronchoscopy or flexible bronchoscopy. This is helpful for biopsies or in conjunction with other procedures. The bronchoscopy is an endoscopic technique in which the tube is advanced in the trachea both through the mouth, nose, or tracheostomy. The rigid bronchoscopy is done for foreign body aspiration or management of advanced airways, and the risk in the rigid bronchoscopy is to damage the lips, the tongue, or the teeth, and rarely pneumothorax. The flexible bronchoscopy, this is used for or helpful for bronchoalveolar lavage, bronchial brushing, endotracheal biopsy, transbronchial biopsy, endoscopic bronchial ultrasound, final needle aspiration. Quickly, we have seen this in other videos. Remember, bronchoalveolar lavage is you infuse saline solution to the tube and you collect that. This is done for diffuse infiltrations in immunocompromised patients, diffuse non-infectious diseases, non-resolving pneumonia, or suspected alveolar hemorrhage. The bronchial brushing is done to assess usually infectious diseases or malignancy, and is taking sample of the lung tissue. The endotracheal biopsy, this is rarely used, but sometimes we do endotracheal biopsy. The transbronchial biopsy is done for pulmonary nodules, acute allograft rejection in lung transplanted patients, and infectious diseases in immunocompromised patients. Final needle aspiration is to assess the metastases in mediastinal lymph nodes, and endoscopic bronchial ultrasound is to assess the walls of the airways and surrounding structures. Indications include endobronchial lesions, intrapulmonary nodules, assessing or staging the lung cancer, and mediastinal lymphadenopathy. Now, so we can see that here in bronchoscopy we have some biopsies like transbronchial biopsy, bronchial brushing, endotracheal biopsy, and final needle aspiration. This is of the mediastinal lymph nodes. And the video-assisted transthoracic surgery. This is a minimally invasive technique, and the indications are similar to lung biopsy, but also pleurodesis, lung or pleura biopsy, and pulmonary contusion. The open biopsy has more risk than the other procedures and will be performed only after minimally invasive procedures have failed to yield a diagnosis, and the patient should get general anesthesia and should stay at the hospital.